Hi, my name is Dr. Catherine Eichard Stewart, and I'm honored to serve as your host and moderator for today's conversation. I'm an assistant professor of gynecology and obstetrics at Johns Hopkins Hospital School of Medicine and the director of the Susan L. Berger, MD, Gynecologic Oncology Survivorship Program. I'm happy to welcome you to our Gynecologic Cancer Awareness Month program, Prevention is Power, Learning the Secrets to Reducing the Risks of Gynecologic Cancers. Over the next hour, we'll explore how knowledge empowers prevention and early detection, focusing on ovarian, endometrial, and cervical cancers, and share clear steps you can take to protect your health. Joining us for this conversation are three distinguished leaders in gynecologic oncology. First is Dr. Amanda Nichols-Fader, who serves as the Vice Chair of Gynecologic Surgical Operations at Johns Hopkins Health System and is the Director of the Center for Rare Gynecologic Cancers. Dr. Fader is also the 2024-2025 President of the Society of Gynecologic Oncology and brings expertise spanning from preventative oncology through survivorship. Next is Dr. Kimberly Levinson. She's the Director of Gynecologic Oncology at Greater Baltimore Medical Center and an Associate Professor of Gynecology and Obstetrics at Johns Hopkins. Dr. Levinson's work centers on cervical cancer prevention, surgical innovation, and addressing health disparities. She is also the principal investigator with the SPORE in cervical cancer. And joining us shortly will be Dr. Rebecca Stone, the director of the Kelly Gynecologic Oncology Service and an associate professor of gynecology and obstetrics at Johns Hopkins Medicine. Her clinical and research focuses on the early diagnosis and treatment of gynecologic cancers. Today's conversation will focus on the key risk factors you should know, early warning signs that shouldn't be ignored, prevention strategies that you can implement today, and cutting-edge research and emerging trends shaping gynecologic cancer prevention and early detection. Before we begin, I'd like to remind those watching live that you can submit questions using the chat feature below. We'll be monitoring questions throughout the program, and we'll answer as many as we can during the Q&A segment towards the end of today's broadcast. And just a reminder, as treating physicians, we can answer general questions, but we cannot answer any specific treatment-related questions. So without further ado, I'll turn it over to Dr. Fader to start her presentation.
Thank you so much, Dr. Stewart. Hello, everyone. I'm going to be focusing my talk today on prevention of endometrial cancer, otherwise known as a womb for improvement. And as GYN oncologists, we primarily take care of patients who are already diagnosed with one of the 5 gynecologic cancers. However, I would argue that for many of us, one of the most important things and one of the favorite things that we do is preventive oncology, the opportunity to prevent cancers from developing altogether in both low and high risk women. And there's many approaches to improving cancer incidence and survival, with prevention, screening, and early detection being among the most important things that we can do and what we're going to focus the webinar on today. And one of our colleagues at the National Cancer Institute, the noted cervical cancer scholar Philip Castle, once said, "The best cancer is the cancer that never happens." And I would absolutely wholeheartedly agree with that. And we're going to talk to you today about those secrets of how to really improve your health and prevent, in my case, endometrial cancers. And I'm going to be focusing today on the role of obesity and weight, abnormal uterine bleeding assessments, and opportunities to perform what's called a risk-reducing hysterectomy to help prevent those cancers, and the many different ways we seek to prevent or screen cancers, from testing to medicine, surgery, and vaccines. And there's really been a revolution in GYN cancer prevention in the last 15 years, with tremendous advancements in vaccine progress that you'll hear about today, genomic and molecular profiling improvements, novel screening and surgical approaches, and precision-based prevention strategies, meaning strategies tailored to the individual patient about your unique risk factors that we can help you to empower you to prevent disease. What's important for everyone to understand is that cancer is becoming the leading cause of death in the US. So it's really important that we focus on prevention as a measure here to improve the health of populations. And it's been one of the top 2 leading causes of death in the US for over 90 years. But in the early 1900s, the US went through a huge epidemiologic transition in which chronic diseases really displaced acute infections as the leading causes of death, with heart disease and cancer really rising in those early 1900s until recently. But now the US is undergoing through another transition in which cancer may eventually become the leading cause of death nationally. And when we look at cancer in women in particular, by 2014, cancer became the leading cause of death in 22 states, and for women less than 85 years of age became the leading cause of mortality. So it's really, really important that all women are empowered to understand opportunities to prevent cancer, and especially the female cancers. And that's because when we look at trends in cancer across men and women and all genders, we see that cancer incidence is rising in women and decreasing in men over time. And a big study performed at the American Cancer Society and the CDC demonstrated that there's an 82% higher rate in women occurring than in men under age 50. And that was done in 2021. And in this study, what was really alarming to see was that endometrial cancer, uterine cancer incidence and mortality really was increasing in both younger and older age groups in the last two decades. And I would, as an endometrial cancer researcher and clinician, I would describe this as a 5-alarm fire, and something that why we're really focused on researching this in the US and at Johns Hopkins. And when you look at cancer statistics in women over the last basically 20 to 30 years, we see that breast cancer is the leading cause of cancer in women, and you see that uterine corpus or endometrial cancers round out the top 4 common causes of cancer. And back in 2012, there was about 58,000 cases per year diagnosed. Well, in 2022, that increased to 65,000 cases. And you can see that the colon cancer, which is the 3rd leading cause of cancer in women, kind of remained static, while uterine cancer cases really kept increasing. If these trends continue, by 2032, the American Cancer Society and the CDC predict that uterine cancer is going to overcome potentially both lung and colon cancer as the 2nd or 3rd leading cause of cancer in women. And so researchers like our team at Johns Hopkins are really dedicated to reversing these trends and understanding how we can prevent these cancers in more women. And the good news is that GYN cancers are largely preventable. Approximately 50 to 60% of all cancer cases arise from modifiable risk factors such as diet, lifestyle, viruses, tobacco, environmental toxins. And I would argue that 60 to 70% of all GYN cancers are avertable. Let's talk specifically about endometrial cancer. While the incidence of many cancers around the world have plateaued or decreased, including breast and colon cancers, endometrial cancer is one of the only cancers that's rising in both incidence and death rates, with doubling of mortality seen over the last 30 years. There's been a specific rise in higher risk endometrial cancers, the less common, rarer types. And we are also seeing a rise not only in postmenopausal women or women who've undergone the change of life, but in premenopausal women too, which can impact their fertility and lifestyle. Endometrial cancer also exhibits one of the largest Black-white survival disparities in cancer medicine, with Black individuals having a much higher, 2 times the mortality rate than that of white patients or individuals. And this disparity is driven in large part by, again, those rarer subtypes of endometrial cancers. What is really important that we all understand is the relationship of endometrial cancer to being overweight or obese. Obesity is one of the strongest modifiable risk factors for endometrial cancer and is attributable to up to 50% of all endometrial cancer cases and associated with upwards of 80 to 90% of all endometrial cancers. So we talk a lot about obesity and heart disease and diabetes and those kinds of things, but what's really important for everyone to understand is how closely obesity is linked to cancer incidence and development. And I would argue that endometrial cancer is the most obesity or overweight associated cancer in men or women. What about screening for endometrial cancer? Well, the national regulatory bodies that decide on screening for cancers currently does not recommend routine screening for endometrial cancer in women who have no symptoms or are at low or average risk. There's no standard screening for this type of cancer, but there's a focus on early detection through regular gynecologic evaluations and prompt reporting to physicians if you have symptoms of abnormal bleeding or spotting either between your menstrual cycles or you have abnormally occurring periods that develop that are different than your regular menstrual cycles, or in postmenopausal women, any bleeding or spotting at all is completely abnormal and needs to be evaluated by a healthcare provider. And there's also genetically high-risk women. There's women with a syndrome called the Lynch syndrome, which have an even higher elevated risk of endometrial cancer. You can see here in this little pictogram of a woman off to the right here that the Lynch syndrome can contribute to the development of many, many cancers, most commonly, though, colon and endometrial cancers. So in high-risk women who have a strong history of colon or uterine cancers or endometrial cancers in their family, we recommend close screening, potential genetic testing. So knowing your family history is a key way you can help prevent cancers in your family or yourselves. Really paying attention to that, talking to your healthcare provider about whether you need genetic screening or not, because we can potentially intervene once a woman has completed childbearing, if she wishes to have children, by performing what's called a risk-reducing hysterectomy to remove the organ that could potentially cause cancer and prevent that cancer altogether. Depending on the type of Lynch syndrome mutation, we sometimes recommend removing the ovaries as well, because those can be associated with ovarian cancer can be associated with the Lynch syndrome in select cases as well. And we usually recommend doing these risk-reducing strategies by age 40 to 45. What about patients on tamoxifen? Many of you may recognize the word tamoxifen. It's a drug that's used to help block estrogen formation that can cause breast cancer, for example. It's also used to treat other estrogen-positive tumors. And there was a really large study looking at, the hundreds of thousands of women that go on tamoxifen and can improve their survival when they have an estrogen-positive breast cancer. But what women need to also understand is tamoxifen can also cause endometrial cancer because it can abnormally stimulate the menstrual lining to proliferate. And so we do recommend that any woman on tamoxifen really report if they have any signs of abnormal bleeding at all while they're on this, to please consult with their gynecologist or their oncologist to let them know, because although most tamoxifen related developments in the uterus are going to be benign, like benign polyps or growths, there could be up to a 4-fold risk of endometrial cancer. So it's really important for women to know this. I think it's also important to understand sort of what the risk factors and symptom awareness barriers are. There was a very large study done in Texas showing that 60% of patients who were queried about endometrial cancer had no knowledge of the symptoms or risk factors of this disease, such as the most common symptom of endometrial cancer is abnormal uterine bleeding, again, in premenopause or postmenopause. And abnormal uterine bleeding should never be ignored, and we really strongly recommend it be evaluated by your physicians should you have those experiences. Obese women, in particular women who are overweight who have abnormal uterine bleeding, are at particularly increased risk, and so it's really important not to ignore those symptoms. Providers, primary care providers and internists, we're working to educate them as well so they understand those symptoms and don't blow women off when they come to see them about those symptoms. And this is a nice diagram created by one of our colleagues at Hopkins about all the different potential causes of abnormal uterine bleeding. And fortunately, most of the time it's not endometrial cancer, but it's important to find out the cause if it occurs. And in some cases, it will be a precancer or cancer of the uterus that needs to be immediately treated. And the American College of Obstetrics and Gynecology does recommend that in the setting of abnormal uterine bleeding, especially in high-risk women, that an endometrial biopsy be performed in the office just to make sure you can get an ultrasound to evaluate this, but also the gold standard is really to get a tissue biopsy to ensure that there's no disease there that needs to be treated. And my colleague, Dr. Anna Beavis, and I and others at our center did a study looking at what are the risk factors for endometrial precancer or cancer in young women who present with abnormal uterine bleeding. And we found that women who had a body mass index of over 50 or were morbidly obese and had other medical conditions such as polycystic ovarian syndrome, PCOS, or diabetes, some of them had up to 28 to 36% risk of having precancer or cancer of the uterus. And so sort of understanding those risk factors and who's at highest and lowest risk is really important. We also conducted a study of preferences with this kind of screening in women who are at higher risk. And many patients reported being willing to undergo an endometrial biopsy at very low risk thresholds for endometrial cancer so that we could help prevent or treat those cancers at a very early stage. But early detection of hyperplasia, which is the precursor of endometrial cancer, as well as endometrial cancer, is possible, but it does require symptom recognition by both patients and healthcare professionals, and an understanding of the limitations of tools like transvaginal ultrasound and the unreliability of symptom severity. So even if you have just a tiny bit of spotting and you think, it's nothing, it's only happened once, well, that could be an early sign of a cancer. And so just because it's not heavy bleeding means it should not be ignored. So please have a low threshold to get something evaluated like that if you have a symptom of concern. If you feel something, say something to your providers. The opportunity to really prevent endometrial cancer is huge. It's a very modifiable cancer. And about 50 to 60% of new cases are directly attributable to being overweight or obese. Most are preventable with lifestyle changes or with something called hormone therapy or progesterone therapy, an important hormone that our ovaries produce. And prevention opportunities in women who are overweight exist, including use of the progesterone-containing or levonorgestrel intrauterine device, which results in a 50 to 60% reduction of risk of endometrial cancer. Progesterone-containing contraceptives, which offer a 30 to 40% risk reduction. Bariatric surgery or weight loss, which can offer 60 to 70% risk reduction. And the new GLP-1 inhibitor receptor agonists offer huge opportunities here. This new class of drugs offer risk reduction of up to 40 to 60%, especially when combined with progesterone-based therapy. So there's a lot of medical and one surgical opportunity here. I'd like to end by talking to you a little bit about the research we're doing here in early detection and screening. As you may recall, I said there's no approved screening test for this disease. And what we're trying to look at are what are the molecular or the invisible, if you will, or very microscopic risk factors or mutations in tumors that we can study. What are their biomarkers, if you will, that can signal to us that their cancer is there, and how can we create screening tests around that? And you can study biomarkers that are proteins or circulating genetic material from the tumors in the blood, in fluid, in the vagina, and other areas. And we at Johns Hopkins, in conjunction with the great Dr. Bert Vogelstein, have developed what's called the PAP gene test or the PAP-seq test, where we're evaluating the DNA or the genetic makeup of tumors from endometrial, and we also studied ovarian cancers, and we found that they had a specific genetic signature, that these tumors had specific genes that we could reliably detect in pap smear fluid and using simple pap tests in the vagina. And we were able to confirm tumor mutations in the pilot study in 24 out of 24 patients with endometrial cancer. We did an additional study in more than 300 patients and found a very high sensitivity and specificity for detection of endometrial cancers in the vagina. And so this is not ready for prime time yet. We're continuing to study and refine this test, but we're really hopeful that one day we might be able to offer a novel screening test that's not too invasive for patients, that's similar to a pap smear, which I know Dr. Levinson is going to talk about. My colleague, Dr. Jamie Backham-Gomez at the Mayo Clinic, is also studying this at the Mayo Clinic, and she's using, instead of a pap smear brush, she's using tampons to collect this DNA material. So in summary, there's lots of strategies to reduce endometrial cancer incidence and hopefully improve mortality rates. We know that screening is not used now in low-risk patients, but we're studying ways to do this in high-risk patients. We know that there's opportunities for early detection through symptom recognition and early approach to medical doctors for us, and to prevent it with several strategies. And again, any abnormal uterine bleeding is going to be effectively prevented if you seek care early for that. And so I just issue a call to action to all of our listeners to pay attention to those symptoms and screening opportunities. This is a very preventable cancer. Please pass along what you learned today's webinar to at least 10 other women in your life, because women-to-women education can be very empowering and really give you the know-how to help prevent cancer. Thank you so much.
Thank you so much, Dr. Fader. Before we move on to our next presentation, I'd love to ask you a quick question. You briefly mentioned in your presentation the use of the IUD to treat or prevent endometrial cancer. How do you typically counsel patients regarding the use of an IUD when contraception is no longer needed? And is this device safe to use in postmenopausal women?
It's a wonderful question, Dr. Stewart. I find that the IUD has so many non-contraceptive benefits, and among them, the reduction in the risk of endometrial cancer and its precursors is among the most important. It's very safe, very healthy thing to utilize well into menopause for women who are high risk with appropriate procedures in the office and pain medication, it can be inserted with ease in most office settings. So I would talk to your providers about whether you're a candidate for that.
Thank you again. I'm sure that we will get a lot more questions from our audience, and we will answer those at the end. Up next is our presentation from Dr. Kimberly Levinson.
Thank you so much, Dr. Stewart. I'm very excited to talk with you all this evening about the prevention of cervical cancer. This is a topic that I'm extremely passionate about. And I think if not clear already, it'll become clear throughout the evening, as Dr. Fader mentioned, that even though we treat these cancers every day, prevention is really one of the best things that we can do for our patients. And so we're really excited to bring this information to you this evening. So this evening, I'm going to briefly discuss current trends in human papillomavirus and cervical cancer. I'm going to discuss the best strategies for prevention of cervical cancer. And I'm also going to introduce to you some of the research that our team at Johns Hopkins is currently working on in the prevention of cervical cancer. So first, I'm going to discuss some of the epidemiology of HPV and cervical cancer. The human papillomavirus causes approximately 730,000 cases of cancer per year, which is almost 4% of cancers overall. This map shows the distribution of these cancers worldwide, and it's really important to recognize that there's great variation in the distribution of these cancers. In parts of Africa, HPV attributable cancers are as high as 38%, whereas in the US, they are only 2% of cancers. While HPV mostly affects cancers of the lower genital tract, including the cervix, vulva, vagina, anus, and penis, oropharyngeal cancers can also be HPV related. And while about 30% of oropharyngeal cancers are related to the human papillomavirus, almost 100% of cervical cancers are caused by HPV. These maps here show the incidence and mortality of cervical cancer globally. And again, the distribution of this disease is clear. So you can see that 9 out of 10 new cervical cancers are really in low middle income countries where access to vaccination and screening and treatment are really limited. Furthermore, women with HIV are 6 times more likely to develop cervical cancer than their HIV negative peers. So when we talk about cervical cancer, it's really critical to recognize that even though this disease is less common in the US, cervical cancer is the 4th most common cause of cancer deaths worldwide. And you can see that here in this graph, where you can see cervical cancer here at the top for women in orange after colon and rectal cancers, breast and lung cancers. So in the US, there are just over 13,000 cases of cervical cancer each year, and this disease causes approximately 4,300 deaths per year. And if we look at the incidence and mortality over the last several decades, we see a significant decrease in the incidence of cervical cancer since about the 1970s, which is largely due to preventive efforts. In thinking about HPV and cervical cancer, it's important to understand that the HPV virus has approximately 200 genotypes, not all of which can cause cancer. In fact, only about 19 types are directly related to cervical cancer. And what we have come to understand about HPV genotypes is that 2 types in particular, types 16 and 18, are really the most what we call oncogenic, or the most likely to cause cancer. And those 2 types alone are responsible for about 70% of cervical cancers. Type 33 is responsible for another 5% of cancers, and 8 types altogether are responsible for approximately 90% of cancers. And distribution of these various types can be differentially prevalent in various parts of the world. And we know that in the developing world, types 31 and 45 are actually quite prevalent as well in cancers. So knowing this information, what can we do about prevention? Are there signs and symptoms that can lead to early diagnosis? So for cervical cancer, primary prevention, meaning preventing disease before it ever occurs, is really one of the best things that we can do. We know that this is the best way for us to prevent cervical cancer by preventing infection with HPV virus. The first FDA approval for HPV preventive vaccine was in 2006. And with the introduction of the preventive vaccine, we gained the ability to completely prevent cervical cancers. Studies have very clearly shown that this method of prevention is efficacious, showing that when we compare pre-vaccination and post-vaccination periods in multiple countries, particularly in the younger age cohorts where patients were able to undergo vaccination, the prevalence of the HPV types included in the vaccine were significantly decreased. And you can see that here in the graph on the chart. The issue with primary prevention at this time is twofold. So first, coverage and access remain quite limited. And the second thing is that patients who have already been exposed to HPV are not protected with preventive vaccination. So on the left here, you can see that this graph shows global figures, which again show great disparity in the preventive vaccine coverage around the world, with the most at-risk areas less likely to have vaccination. And even in the US, as of 2023, only approximately 60% of girls and 55% of boys were vaccinated. So what about secondary prevention? Secondary prevention refers to those interventions that are aimed at detecting disease early. So for cervical cancer, there is a long process for cervical cancers to develop, starting with infection of the cervical cells with HPV. So you can see that here where it says basal cell and then HPV infection. And that HPV infection, when it persists, causes changes to the cervix, which can lead to low-grade changes called CIN1, and those can then progress with time to precancers called CIN3. Secondary prevention, therefore, involves first screening. So testing for the HPV virus. So here you can see that we can do a test, a pap smear and an HPV test in particular, where we look to see if the virus is present in the cervical cells. The next thing that we need to do is triage patients. So we need to look at the cervix and determine what cellular changes are there. And you can see in this chart here of the cervix that there's various changes that we can see when we do a colposcopy to help determine how advanced those cervical changes of those cells are. And then finally, we can offer treatment. So when we see changes of the cervix or changes to the cervical cells that are significant for a precancerous lesion, we can remove those abnormal cells and that precancerous lesion to prevent further progression of disease. For cervical cancer specifically, primary and secondary prevention with screening tests are critical because cervical cancer often does not present with specific symptoms until later stages. So Dr. Fader was talking with you about bleeding, and bleeding is an early sign of endometrial cancer, but unfortunately, fortunately or unfortunately, cervical cancer doesn't often present with symptoms, early symptoms. And so screening is really our best way to prevent cervical cancers. Unfortunately, once symptoms arise, the disease may already be advanced. So I'd like to share with you some of the research that our team at Johns Hopkins is currently working on through the cervical cancer spore. From my standpoint, one of the most critical issues for cervical cancer, and really for all HPV-associated cancers, is that once a person has acquired the HPV virus, we can't actually get rid of it. The virus can become latent or undetectable, but can recur at any point. And given that this is a virus-associated disease, if we can get rid of the virus, we should be able to cure the disease. And in many ways, viruses may be ideal for immune therapies because they represent a foreign body, and therefore the immune system should be able to be stimulated to recognize them and to get rid of them. However, prior clinical studies have shown that it may be difficult to get an adequate immune response to these therapies and vaccines. When thinking about treating HPV as opposed to preventing HPV with vaccines, it is important to recognize the difference between preventive vaccines and therapeutic vaccines. So preventive vaccines actually cause what we call an antibody response, which effectively teaches the immune system to recognize the virus before it enters the cells. Therapeutic vaccines, on the other hand, are targeted at activating what we call cellular immunity, which is required to attack cells that have already been infected by the virus. And this is called a T-cell response. So several therapeutic vaccines have been developed to HPV. However, they've failed to produce a sufficient immune response. And in our cervical cancer SPORE program, we've done extensive studies to develop therapeutic vaccines that have incorporated what I will call immune flags, with the goal of causing a greater alert, so to speak, to the immune system. Several studies were performed to identify the best immune flags, and 2 different vaccines were developed based on these studies. The first vaccine uses a calreticulin flag, and the second uses a heat shock protein flag. Another strategy that's been investigated has been what we call electroporation, which is a mechanism that we use instead of just a little needle in the arm when you get a vaccine. Electroporation actually causes stimulation of the muscle at the site of vaccination. And we know that this helps increase the uptake of the vaccine and increase the expression of the targeted gene by 2 to 3 times. So the graphs here show preliminary studies that we did comparing intramuscular injection to electroporation. And you can see here that the immune response is significantly increased when the vaccine is delivered by electroporation. So just to wrap things up, our groups currently has 3 different studies that we're working on, 2 which are currently enrolling and 1 in pre-enrollment phase. So I'm just sharing some preliminary data here on 2 of our studies that have been enrolling. The first study looks at low-grade dysplasia, so early changes, and we look at conversion of HPV-16 to undetectable. And on this graph here, you can see that the green shows where patients have converted to HPV undetectable. And so in the low dose cohort here, the 0.3 milligram dose, we did not have any responders, no patients converted to undetectable. Whereas in the medium dose, we had 1 patient out of 3, and in the high dose, we had 5 out of 12. So this really suggests that maybe there's a dose response here, and we are currently in the process of increasing our dose even further to determine if we can get more patients to respond here. Our second study that we're working on is actually in adding electroporation to see if, again, we can improve responses. And then our other study that we're currently enrolling is a study that we're looking at patients with high-grade dysplasia. And again, this study does use electroporation. And what we've seen here is that the low dose does have some clearance. So again, green suggests conversion of both the dysplasia or the abnormal cells and the HPV. The medium dose, we had all patients actually clear both dysplasia and HPV to undetectable. And in the high dose, we actually had less clearance than in the medium dose. And so there have been some other studies which have actually shown similar findings. And so we're currently expanding this 1 milligram dose to see if we can get some additional evidence that this is working. So I just want to thank everybody. I hope that, again, you'll share this information. And again, prevention is key to everything that we do. And thank you for your attention.
Thank you so much, Dr. Levinson. A quick question before we pivot over to Dr. Stone. What can women do if they have persistent HPV positive results on Pap smear, but no precancerous changes?
Yeah, so this is one of the most challenging situations that women face because they get into a process of screening and biopsy and screening and biopsy and screening and biopsy. And the thing is that unfortunately, once HPV is there, we currently don't have strategies to get rid of it. And so the best thing that we can do is try to continue to screen to make sure that changes to the cervix aren't happening. And if there are early changes, that we pick them up and then can treat to prevent a cancer from forming. Thanks, Dr. Stewart.
Thank you. And again, we'll have a lot more time for questions at the end. So if you're watching live, please add any questions you have in the comments in the chat. Finally, I'm happy to turn the program over to Dr. Rebecca Stone.
Hi, everybody, and happy GYN Cancer Awareness Month. I am going to wrap us up by talking about ovarian cancer prevention. Let's see if I can advance. Which is super important, right? Because a person is diagnosed with ovarian cancer in the US every 40 minutes. Try as we might, there is no effective screening, which makes this obviously very different from cervical cancer. And it is a devastating, often lethal disease. And you can see on the right that this was a headline that appeared in the Wall Street Journal in 2000, basically calling attention to the fact that ovarian cancer is a disheartening outlier in the progress made towards decreasing the global burden of cancer. And I would say that this has not changed enough over the past 25 years. And I am obsessed with doing something about that. And one of the reasons it hasn't changed enough is because even our best, newest treatments for newly diagnosed ovarian cancer and for recurrent disease typically only provide a short time in remission. So they don't afford a cure. And, what if, though, this short time, these months, what if that could be never? What if we could go from months to never and people could never get ovarian cancer? That is a possibility, and that is possible through prevention. So, ovarian cancer prevention so far really has been targeted almost exclusively to high-risk individuals. So people who have had genetic testing and have a genetic change that is associated with increased susceptibility. It makes good sense that this has been the case in ovarian cancer because when you look at graphs like this, ovarian cancer really has outranked many other cancers when it comes to the number of cases that are linked to hereditary gene mutations, with BRCA being the most common and conferring an incredibly high lifetime risk of ovarian cancer of between 20 to 40%. And, for high-risk women, again, women who have, genetic risk for ovarian cancer, we have really focused on ovarian removal when it comes to ovarian cancer prevention, which makes sense, right? It's called ovarian cancer. And typically this is recommended between the ages of 35 and 50. So to young women who are premenopausal. So it's a strategy that's been, very effective for high-risk women, but it comes at the cost of premature loss of ovarian function and all of the related health consequences of that, let alone, the effect on quality of life and sexual function. So because of that, only 1 to 3 at-risk women, so again, women who have this substantially increased risk of ovarian cancer due to mutations, many of whom have buried their mother, their sisters, from the disease, actually choose to have their ovaries removed, between the ages of 35 and 50. The majority actually present to risk-reducing surgery later than recommended age or not at all. Why is this? Again, because many are very fearful of menopause and they cannot find a provider who will prescribe them hormone replacement therapy. And when prevention is focused so heavily on high-risk individuals, we miss other opportunities as well, right? So only a few of the first-degree relatives of high-risk women actually go on to get genetic testing themselves, even though they're at a 1 in 2 chance of having the same increased genetic risk. I think relying on things like family history, right, to recommend genetic testing to a person in the first place is really problematic. We know that family history is negative in 30% of genetically at-risk women. And so since their family history is negative, no one offers them to get genetic testing. And then they find out that they have a gene mutation like BRCA only after they're diagnosed with ovarian cancer. And this really represents a major failure in prevention. And then lastly, like I alluded to at the beginning, the vast majority of ovarian cancer cases are diagnosed in women who seemingly have no risk factors. They just seem to come from nowhere. They have no genetic risk. And so, what if a strategy existed that could transcend all of the limitations of prevention that are based upon, family history and genetic testing? And what if we had a practical approach for broadening prevention to all women that did not require them to have their ovaries out, at a young age or potentially at all? Well, we do finally have such an amazing thing called salpingectomy, which means fallopian tube removal. And why do we have this? Because of the discovery that the most common types of ovarian cancer actually come from either directly or indirectly from the fallopian tubes. And this discovery was made more than or just about 25 years ago. And where do these cancers begin? They begin in the fimbria of the fallopian tube, the little finger projection that interacts with the ovary. So prevention strategy that's based upon ovarian removal, not so great, not many takers there. But one based upon fallopian tube removal is reasonable. It might be even exciting because the fallopian tube, doesn't make hormones ever in its life. The ovary does that. And it doesn't have any known form or purpose beyond reproduction. Its purpose is simply to serve as the rendezvous for a ovary coming from the egg and a sperm coming up from the uterus. And once you don't need that rendezvous anymore, then you don't need your fallopian tubes and you can have them removed for prevention. So, this discovery of the fallopian tube origin of ovarian cancer really has led to a major paradigm shift in prevention. And the number one eligibility criteria for prevention of this nature is hopefully fairly obvious to you guys who are listening at this point, which is simply that you have to not need your fallopian tubes for future fertility. And that's pretty much all of us, who are approaching menopause, newly menopausal, et cetera, but also, can be the case for many other people as well. People who want to have kids by other ways, for example, who don't want to have kids. And so, when you think about then the different categories of women, we've talked a lot about high-risk women, right, where we focused all of our prevention efforts for the last decades. These people are thinking about having their fallopian tubes removed as soon as they're done with family planning and then waiting to have the ovaries out until closer to the natural age of menopause. It's a huge change for this group of women. And this is being studied in a large international trial called TUBA-WISP. You have moderate risk or intermediate risk people who face a 2 to 4% lifetime risk of ovarian cancer. A lot of the people who are in this category are folks who have a family history of ovarian cancer but have negative genetic testing, and they really want something that they can do, to decrease their risk. And right now, we recommend that these people consider having their fallopian tubes removed as like a standalone procedure 10 years earlier than the youngest affected family member. And then you have everybody else, right? The like 99% of the rest of people in the world who simply are at risk because they have fallopian tubes. And in this case, we recommend something called opportunistic salpingectomy, ideally done at or around the age of 50 or earlier if family planning has been completed. And we recommend 50 being the age threshold because there's some recent data out of Denmark that indicates that after 50, the amount of protective benefit may go down some, and we're not really sure why that is. But opportunistic salpingectomy is just simply taking the opportunity to remove the fallopian tubes when somebody is having some other procedure done, whether it's a hysterectomy or you are going in for a tubal ligation and you want the dual benefit of pregnancy prevention and ovarian cancer prevention. You could choose to have your tubes removed instead. Or one area that we're working right now is, can we broaden this outside of OBGYN, bring it to general surgical practice more broadly, and women can opt to have fallopian tubes removed at other procedures like a gallbladder or hernia repair or what have you. So we now know, based upon data that is starting to come out of British Columbia, Canada, where they've been working on this for quite some time, that simply removing the fallopian tubes reduces the risk of serous ovarian cancer, which is the most common deadly type of ovarian cancer, by a projected 80% in the general population. And so the Canadians have been looking at, what is the risk reduction at the population level of making salpingectomy available to women instead of tubal ligation and at the time of hysterectomy. And it appears that it's going to amount to an 80% risk reduction. There is no other risk reduction or statistic like that I have ever encountered in my career as a doctor. And it's staggering and amazing. Well, okay, what are we doing in the US? Usually at this point, when I'm talking about this, people are like sort of alarmed because they're like, oh my gosh, unless you know me and you hear me go on and on for hours and hours on end in clinic, no one has ever heard about this. And you're not alone. Like when I sit and talk to people of, major authoritative organizations, whether it be the CDC or the American Cancer Society, actually many people there don't know either. So don't worry. But the bummer is in that the US, although we've had a recommendation from our college and from the SGO since 2015, it has not become a standard of care that we can be proud of yet. And so, in 2021, the fact that almost no one had ever heard about this, and I was spending, every minute of every day taking care of people's loved ones who are affected by this disease, knowing that, the projections are that we could prevent thousands of cases of ovarian cancer and save so much money in terms of healthcare costs if we simply made salpingectomy an option instead of tubal ligation. And at the time of hysterectomy, this made me absolutely crazy. So I was like, okay, we're going to start this thing and we're going to call it the Outsmart Ovarian Cancer Campaign. And our goal is going to be to eliminate ovarian cancer by ensuring that prevention, particularly salpingectomy for ovarian cancer prevention, becomes the standard of care, known and accessible to everyone through education, advocacy, and innovation. And it started out as me calling my best friend Carol Long, and then we called some of our other friends and they called their friends. And before we knew it, we had this very large collaborative, which really unites surgeons and epidemiologists and implementation scientists and medical coders and communication strategists and medical illustrators and filmmakers and educators, health law experts, and patients. And this is across Hopkins and Sloan Kettering and MD Anderson and MIT. And the job of the collaborative is to essentially build the health services infrastructure, the knowledge mobilization, and the scientific framework to translate the discovery of the fallopian tube origin of ovarian cancer out of the lab, out of the journals, out of the textbooks, and into the world so that we can save people's lives. And so far, we've been doing things like working with the NCHS of the CDC to establish new ICD-10 codes for salpingectomy for ovarian cancer prevention so that it can be a recognized and reimbursable and measurable standard of care. And we've partnered with Harvard's CHILPI and the National Women's Law Center to pursue health policy and reimbursement reform, right? Because just because you have a code doesn't mean insurance is going to cover it. So we have to fix that big problem. And we've invested in community engagement by partnering with the Bloomberg School of Public Health to study cultural barriers and develop human-centered prevention messaging and establish a community advisory council. And this is a picture of them here from our meeting in January. And we've created a lot of unique knowledge mobilization tools, like an evidence-informed website that has multimedia curricula for patients and providers, which will be launching at the end of the month in celebration of ovarian cancer or GYN cancer awareness. There are other cancers besides ovarian cancer. And we've been working on some filmmaking for storytelling and narrative to try to build trust and reach people where they're at. And, a big strategy that we are focusing on in knowledge mobilization and teaching people about this is really embedding information about this at the times when women are interfacing with the healthcare system and receiving information about prevention for other cancers like cervical cancer, pap smears, breast cancer screening, colon cancer screening, and replacing, things that we all have in our clinics, like this poster on contraception, with updated versions that add in salpingectomy and that tell a person not only how effective these things are in decreasing the risk of pregnancy or preventing pregnancy, but also in terms of preventing ovarian cancer. And then we've been working on the scientific framework. So we've been doing some trials of salpingectomy at the time of non-gynecologic surgery. This has been some of the most satisfying work. So in the first 11 patients who had their fallopian tubes removed at colectomy for colon cancer, we intercepted one left fallopian tube cancer. And in the first 15 patients who had a salpingectomy at radical cystectomy for bladder cancer, we intercepted one serous tubal intraepithelial carcinoma or precancer. And honestly, that we might be able to save someone from the clear and present danger of the cancer, that they're currently dealing with or facing from a second cancer that they didn't even know that they were going to have years after they finished treatment for their first is like honestly a dream come true. And then my current obsession is, forging a path to credible U.S. epidemiologic data so that we don't just have a nationally coordinated public health campaign that is focused on raising awareness. That's important. But we want a smart one, right? A campaign that can tell us who's being left behind so that we can target our education and resources there. And this has been quite urgent, setting this big thing up, this big data thing, because our new ICD-10 coding is going to be live October 1st. And we're preparing to head to centers like Cleveland Clinic to engage with their legion of surgeons that are undergoing credentialing to offer salpingectomy at the time of non-GYN surgery. And so an ounce of prevention is worth a pound of cure. Ovarian cancer prevention matters. And thank you guys for tuning in. Oh, wait, I'm supposed to do one thing or Ashley Ostrega will kill me. Save the dates. Stride and Thrive, baby. On for June 7th, we're going to be at the zoo again. That is back by popular demand. And the registration opens very soon, so look out for that. And please join the race committee. It's super, super fun. And we're going to have our kickoff meeting on October 9th at 5:30 p.m. at the Mount Washington campus. And to receive an invite email, please shoot us an email at gynobhopkins@jhmi.edu. Thank you.
Thank you so much, Dr. Stone, and for the quick shout out about Stride and Thrive. It's been so wonderful to talk about all of this, and I'm sure we could chat about this for another hour or two, but I'd like to turn over to our audience and see what questions we have had coming in. We will do our best to respond to as many questions as we've gotten, but we've gotten quite a few, so forgive me if we do not get to the question that you entered in the chat. So we're going to start with our first question. So if you don't have children, does it increase your risk of uterine cancer?
That's an excellent question. Yes, it does slightly increase your risk, but the most important modifiable risk factor for endometrial cancer, as we discussed, is being overweight or obese, or having an exposure to either internal high estrogen levels or receiving exogenous or external estrogen through medication without balancing that with progesterone. But yes, that is a mild risk factor.
Next question is chemotherapy and radiation a must treatment for all cancers?
I can pop in and answer that. So, recommendations for treatment for cancer are usually specific based on the stages of cancers and certain risk factors that are identified, usually on pathologic findings. And so each person's individual risk factors are assessed by their provider, and recommendations will be made depending on the risk of each cancer.
So the next question specifically pertains to uterine ablations. If a uterine ablation is used to reduce excessive bleeding, is the cancer risk reduced or is it still high?
Another wonderful question. There was a very large retrospective study of over 200,000 women, and they looked at endometrial ablation, and it neither really decreased nor increased the risk of endometrial cancer. A lot of women also asked, does it delay the diagnosis of endometrial cancer because that menstrual lining can be cooked or burned, if you will, with this procedure, that is an option for some women who have abnormal uterine bleeding. And in most cases, it was still detected at an early stage and did not impact survival. But abnormal uterine bleeding, vaginal bleeding after ablation, it's very important that that's worked up because that can occur in up to 15 to 20% of women.
Next question is for Dr. Stone. Are cancerous tumors large enough to be seen in the fallopian tubes or ovaries during a pelvic ultrasound?
That's a great question. No, unfortunately, we actually don't have any imaging techniques that are routinely used in medicine that can even see a fallopian tube, let alone the small cancers that start in the fimbriated end.
And just a follow-up question to that, what is the difference, Dr. Stone, between a salpingectomy and a tubal ligation, and why is that important?
That's a good question. So this comes up a lot. A tubal ligation essentially is a way to achieve permanent contraception or sterilization where, the midsection of a fallopian tube is typically removed, or a clip or a tie is put across the midsection of the tube. And so it doesn't typically remove any of the fimbriated end where these cancers are most likely to begin. And a salpingectomy, the entire fallopian tube is removed. And so all of those fimbria are removed. And so that's why salpingectomy is much more effective at decreasing ovarian cancer risk than a tubal ligation.
Next question's for Dr. Levinson. So there's been a lot of questions about the HPV vaccine. So a few questions are, how long does the HPV vaccine last? And why is there an upper limit on getting a preventative vaccine, even for women who test negative for HPV?
Yeah, so both excellent questions. So in terms of how long it lasts, the ultimate answer is we don't actually know. So, there are studies that are continually looking at the immune response, and there are studies that have measured even after a decade and show that there still is strong immune response, even a decade after vaccination. So, we think that protection is prolonged, but exactly how long we don't know. And then in terms of the second question regarding why is there an age limit to the HPV vaccine? So these guidelines were essentially set based on the way that most preventive screenings are made. So it looks at risks and benefits. And we know that most women are exposed to HPV at an early time frame. And then if we can catch women early on, that is the best place for us to protect women. That's where we get the most bang for our buck from a prevention standpoint. That being said, there can still be benefit to women who may not have been exposed to HPV and could still benefit at later ages as well.
All right. Next question is regarding what is HRT safe after preventative hysterectomy and oophorectomy?
I think both of me, probably all of us can answer this, but I think that's a very broad question. I would say in general, yes. And in particular, when a patient has had a hysterectomy, that means that the hormone replacement therapy can be given just as the estrogen part of hormone replacement therapy. And we know that is the lowest risk, way to receive hormone replacement therapy.
And just a follow-up regarding that, is the use of birth control pills still considered a way to potentially lower the risk of ovarian cancer?
That's a great question as well. So this is very old data from like the 1980s. And the answer is yes. And, when I showed you that poster that Abigail Rump made from Art is Applied to Medicine, that is one of the reasons we made that poster, because when we talk to people out in the community, most people did not know this. We think that everybody knows these things. And, but it decreases the risk by maybe 40 to 50%. Still, quite a good risk reduction if you don't, not interested in having surgery. But the important caveat is that risk reduction is seen in people who take birth control pills consistently for at least 5 years. It doesn't have to be like for 5 years in a row. It could be like 2 years and then, you have a baby and then you take them for 3 years or something like that. But still, you need to to take them, for quite some time to get that risk reduction.
Okay, one last question. There are so many that we couldn't quite get to, but so specifically for a patient who is 50 years old or greater with an average risk of ovarian cancer, are you saying that salpingectomy would not be recommended as a standalone elective procedure to prevent ovarian cancer?
So not at this time. Again, the idea is that, for average risk, right, you meaning no family history, no other identifiable risk factors. And this can be quite a nuanced discussion. So, for a lot of these things, I recommend, coming to see a GYN oncologist to have this conversation. But, for somebody who's purely average risk, that means you have a 1 to 2% chance of being diagnosed with ovarian cancer in your lifetime. And as a standalone surgery, going to this OR for that alone, for anesthesia and the procedure, maybe the risk is equivalent to, your lifetime risk of developing ovarian cancer. It could be slightly higher, right? Just in terms of surgical risk. And so right now, that's why we recommend for average risk people, we recommend the lowest risk scenario, which is opportunistic salpingectomy, like when someone's already there anyways, doing a hysterectomy, or you were planning to have a tubal ligation, and so now you're going to flip over and have a salpingectomy, or you're having some other procedure on the abdomen.
Okay. Thank you so much for that. And unfortunately, we're going to have to be the last question of the night as we're approaching the end of our event. Thank you so much, Dr. Nichols-Fader, Dr. Levinson, and Dr. Stone, for taking the time out of your busy schedules to share the important work you're doing with the Hopkins community. I'd also like to thank everyone who tuned in today to listen to our conversation. We hope you enjoyed the discussion and encourage you to attend more of the Hopkins at Home's free public virtual content in the future. For more information, you can visit hopkinsathome.jhu.edu. Thank you guys again so much, and hope you guys have a wonderful night.